And the idea or the premise of the law is to make healthcare more affordable and more accessible to all of those who are uninsured or are not pleased with their current health insurance, and to lower the cost of health insurance.
That's a pretty good explanation. Thank you, Ashley. And he was inaugurated in 2009, but he did sign it in 2010.
Oh,
but it was really close.
Okay.
I knew what you were saying.
Thanks.
Okay. So Obamacare. So it's a U.S. law aimed at reforming the American healthcare system. Its main focuses were providing affordable health insurance, because a lot of us, because of the health insurance premiums are going up every year right now, and so they're trying to help us to actually afford health insurance. It's actually in the name too. Improving quality care and regulating the health insurance industry, because health insurances are charging so much. It's Obamacare is trying to help us with that. And reducing healthcare spending in our country, because we're one of the top spenders for healthcare insurance in the United States, or in the world, sorry. Okay. And it was enacted in March 2010. It was designed to help insurance coverage to be a large segment of the U.S. population. Most of the provisions of the Affordable Care Act took effect in 2014, but others took effect actually 6 months after it was enacted, so 6 months after March 2010. And that's his signature. So it came about following the inauguration. So like you were saying, it was 2009 was when he was inaugurated, and that's when they were thinking of healthcare reform most, especially during the elections. The Obama administration favored legislation that would include a public opinion that would establish a government insurance program that would compete with private plans. So they wanted to create a health insurance system through the government that would help to compete between insurance plans right now. The House passed this Senate bill, and it became law with the President's signature on March 23rd, 2010. The uninsured, I like this little picture. It's really cool. The biggest goal of the legislation was to reduce this number of uninsured people. It is said that within the 3 years of implementation, the Affordable Care Act will reduce the number of uninsured about 60% down to about 21 million. But the people who would be remaining would be those who were illegal immigrants, or those people who were exempt from it or declined to buy coverage. So those rich people, or those big companies who wanted to self-insure themselves. So these people would be paying the penalty or the tax later on. And Medicaid expansion. So this is like the old Medicaid, what it covered. It covered low-income pregnant women, children, the disabled, the elderly, and a few non-disabled adults were eligible. Now, because of the Affordable Care Act, legal and U.S. residents and citizens between 1964 who have household income between 138% of the federal poverty line would be eligible for Medicaid. So there's a big difference, right? That includes guys too, because in this, it doesn't include those younger guys who are eligible, other than those who are disabled and those who are elderly. The Medicaid expansion. So there was like 27 states who filed a suit against the constitutionality of the individual mandate and the requirements that the states expand their Medicaid programs. But in June 2012, the Supreme Court ruled 5-4 that the individual mandate was constitutional under Congress's taxing power, but that the states could not be forced to be to lose federal funding for their existing Medicaid program if they did not implement Medicaid expansion. The federal government is expected to help subsidize 90% of this new coverage, and also because of the 2007 recession, it's been hard on the states and Medicaid programs. So there have been 16 states who have decided not to expand their Medicaid programs.
Alright, so there are several states that chose to expand and chose not to expand. What states do you guys think chose to expand?
Idaho.
California. Always the answer in all of our classes.
Yeah. Alright, yeah, so the shaded blue is going to be the ones that will expand, and the ones in yellow and darker yellow orange will be the ones that will not expand. Idaho happens to be one of them that will not expand. You can tell, maybe you can see your
That's
screen.
Yeah, like this is an older version, but it's not changing.
But will it?
It didn't change with the
I was
last
just,
legislative
I was just
session.
curious, Sorry.
Yeah, as we can see, more down towards the south, it's Texas, Louisiana, Alabama, Idaho are leaning towards no. So the individual mandate, what does that mean? It requires to have at least the basic health coverage. It requires most U.S. citizens and legal residents, those who have been in the U.S. for 5 years, to have health insurance. And exemptions would be religious objections and financial hardships. Also, I looked it up, and if you're in the race of American Indian, you're exempt, or you're incarcerated, meaning that you're in jail. So, what are the 3 key features? Individual incur penalties for going without coverage. Subsidies are provided for lower income, could be below poverty level, and the coverage is to be adequate. More precisely, people must be qualifying coverage. Alright, so people that do not have to buy coverage through an insurance exchange will most likely continue to get their coverage through their employers. Usually this means people that are working full-time jobs, they could have insurance for this reason. And subsidies are only available when coverage is purchased through an individual exchange. There is a tax penalty if a person does not have health insurance, which I will explain later on, and will face in overtime as adjusted with inflation after 2016. So, here are the tax penalties. It starts out with 2014. It says 95 per year, which means per adult, and 47, it's not on the slide, but it's $47.50 per child, which could mean up to $285 per family. 2015, it would be $325 per adult, $162.50 per child, and $975 up to $975 per family. And 2016, which would be $695 per adult and $347 per child, up to $2,085 per family. So basically, these penalties are straightforward and relates to adverse selection. It also prohibits insurers from basing premiums on pre-existing health conditions. So that's the next slide. What do you think a pre-existing condition may be? Anyone tell me? Yeah, I can. Alright, so the next slide is talks about pre-existing conditions. The ACA requires guaranteed issue and prohibits insurers from basing premiums on pre-existing condition. An example that's given is a person that has diabetes or heart condition. They cannot be denied coverage, even if it's a guaranteed issue. They cannot be charged a higher premium because of their health status. So people don't enroll when they need insurance and then disenroll when they don't need it. which might be someone else's case. The tax penalties are supposed to encourage people to buy coverage, health insurance. Also, it raises the risk of not being able to get coverage if medical services are needed and it is not open for enrollment period. Does anyone have questions so far? Yes.
I heard that with the tax penalties, I know this isn't with pre-existing conditions. Is that okay if I ask a question about that?
Go ahead.
I've heard that you can be, especially at least this year, that you can be so many months without being on health insurance and still not be penalized. Is that true?
Isn't it 3? I was ready 3 months before, and there was a good video that I saw online. It's 3 months before. It's January, February, and March, and you should have it by the next week. Anyone else?
Alright, thanks Liz.
Yeah.
Alright, so we're going to be talking about enrollment period here really quick. So as you can see, the enrollment period, the enrollment period for this year has come and gone. It started October 1st, 2013 through and went until March 31st, 2014. Did anyone sign up on the exchange? Can you just tell me a little bit about your experience? Were you successful in it? You can just say successful, not successful, and we can just leave it at that for now.
Do you want me to say more?
If you want to, I just wasn't sure, just
So
on time.
A lot of people had problems before the time that I did it. There were some problems at the very beginning, but I did it at the very end of December. And actually, it was extremely user-friendly, not like most government things. And I understood everything they were talking about. It was really easy to get through, and yes, I was successful. And what they offer is ridiculous. I mean, I get an extremely good deal, and I have to make sure that I don't let those deals influence me to try to stay on them.
Okay,
Yeah.
so just use it now as kind of a pathway to when you have the job.
It's just for my wife who's 26, I'm 25, so I still qualify for my parents.
Oh,
But
awesome.
yeah, my wife is 26, so we did it for her. And seriously, like 70, so if we pay $70, that's not even the full subsidy. We decided not to take the whole thing. $70 a month. We have a $500 deductible and a $1,000 out of pocket. That's ridiculous.
That's awesome.
So I don't know how or who's going to pay for that. But obviously tax dollars. But I mean, yeah.
These poor people.
Just so you understand, I'm gonna get off it. I'm about to get a job, so and graduate.
Awesome. So there was someone else out here. Do you want to share your experience? Successful, not successful?
I was successful, but I did it under Cover California when I was there.
Okay. And is that your state's exchange program? Okay.
But we moved up here, and I don't know of an insurance, open enrollment insurance plan up here or anything, so that's what I was
Cool. Awesome. That's great. So the open enrollment period for this next year will start this November 15th, and will be extended until February 15th of 2015. So those are some good dates to know if you plan on enrolling in the exchange, whether it be your state exchange or the federal exchange. But if you did miss this first deadline, you do qualify for a special enrollment period, and some events that could cause you to qualify this open enrollment for this special enrollment period would be you just turned 26 and you got kicked off the parents plan, or you lost a job and you need to apply for health insurance. There are some other circumstances as well. But you can apply for Medicaid or CHIP at any time of the year. There's no requirements on that, or no restrictions on that at all. So we already kind of talked about subsidies a little bit. But basically what a subsidy is healthcare more affordable, because not everyone has the financial ability to buy the coverage that the Affordable Care Act provides. As Tyler said, the coverage for your life is about $50 a month. 70, sorry. That seems pretty reasonable. That's going to donate plasma like twice a week or twice a month. So that's pretty affordable, but for depending on your family size, you can get subsidies based on your family size as well as your income. And so for families between the 100 and 400% of the federal poverty line, they handle that through the federal income tax system, which these people would receive refunds. So you'll get a refund, I guess, kind of like with your tax refund, it will just kind of be bundled into there as well. And it also works if those people have the money up front to buy the coverage as well. So you have advanced full credit, and this is credit that the government will pay to the individual's insured, the amount of the likely subsidies in advance of them completing the tax forms. And settling up would occur when the individuals filed their taxes for that following spring. And because of the insurer's exchange, it gives them a subsidy and pays the insured the subsidized portion of the premium. So the size of like I said, the size of the subsidy depends on the household income and the cost of the benchmark insurance, and as well as the household income and the size of your household as well. And so if you want a better plan, or wanting a better plan would mean that the individual would spend extra money on that plan, and cost sharing subsidies. Question mark. Anyone have anything to say about that? Okay, sorry.
I think that's the Affordable Care Act in general, right?
Yeah,
Cost
yeah.
sharing.
So you kind
It's
of,
actually another piece of the subsidies that they provide, yeah.
awesome. And
I can touch on it.
we'll let our experts touch on that, because I'm clearly not an expert on subsidies. So a part of the Affordable Health Care Act, or Affordable Care Act, is that your health plan must qualify, and you can't just have a sham insurance just to, say, oh yeah, I have insurance. I know some people, they might like go buy car insurance, like Cuba or Mexico or something. It's not really car insurance. You're just saying you have it to have it. Yeah, that's not going to fly with the Affordable Care Act. So your plan must cover the essential health services, and some of those essential health services or health benefits include ambulatory services, hospital services, mental health services, just pretty much anything you would need to go see a doctor on a daily basis. Of course, it's not going to cover those cosmetic or optional surgeries. Does anyone have any questions over what we've covered?
You guys can listen to me again. Okay. So how many of you are under the age of 26? How many of you are on your parents' insurance? How many of you are going to be turning 26 sometime soon?
Fine soon.
Within the next year. So for those of you who are turning 26 or are over 26, unfortunately you can't rely on mom and dad anymore. I still have a few years, so I'm milking that as much as possible. But for those of you who don't, there's a program called the Exchange. Does anyone know what the Exchange is? Healthcare people, you should know this. Do you want to go for it?
Yeah, that's what we just talked about. It's a group of the insurance companies all put in one place. You can access it and view all of them online. You can see all of them. And the Exchange offers subsidies like we just heard about, and it's extremely cheap insurance.
It's true. It's basically what it is. There's an online program through the government that just has different types of insurance plans. They go through, there's 4 different, there's bronze, silver, gold, and platinum. And and they all correlate with how much that plan pays. So the bronze would pay 60%, the silver would pay 70%, silver would pay 80%, and platinum would pay 90%. Then the consumer or the patient, which would be you, would pay the rest of the percentage to maximum out-of-pocket amount. So like Ashley had talked about earlier, there are some instances where you can still enroll, since open enrollment is now closed for 2014. If you get married, you have birth, you adopt, you lose your health insurance or coverage, you're applying for Medicaid and CHIP. And CHIP is a program that deals with children. If you're in the insurance class, you learn about that. So, and then this is one of the websites, healthcare.gov, that you can go to get coverage. The next one is called e-health insurance. This one is actually pretty interesting. I went on and kind of messed around with it just to see what I would get. You can't find out your subsidy since the enrollment is closed, but I qualified for it was a bronze plan, so it wasn't too bad. But e-health insurance is a national exchange. It offers several different health insurance plans within each state. All they require is your age, your gender, your zip code, and if you smoke or not. And then the website then returns with a list of policies that work for you that you get to choose from. As was touched on a little bit earlier, each state has the option to submit a plan for a state-run exchange. If the state chooses not to, then the federal government steps in and provides an exchange. 17 states and DC have chosen a state-based model, and then 7 states have chosen a partnership between the state and the federal government, and then 26 states have elected for just a federal default option. And then these are the states that have state-based partnerships and federal exchanges. Idaho is a state-based. I'm from Missouri, so my state is a federal exchange. So you can kind of look and see where your state is. And this is our, we're excited because you have to include that. Okay. Does anyone have any questions up to this point before we kind of move on?
Sorry again. What website then? Because I couldn't find the state run for Idaho.
I found, well, we actually used we have a textbook because a lot of us are in the insurance class for the major. And in the textbook it has a list of who does what or which state is with which program. So
I can give you that information.
So we're going to go ahead and move on to our guest speakers. Sandy's going to go first.
Okay, so I'm Sandy Vollmer. I'm with the Eastern Idaho Public Health District. I am in the medical billing department, but I was serving in the role of in-person assister and trainer for the health district through the whole health insurance exchange period. Okay, so I'm really familiar with everything they were talking about up here. The Affordable Care Act does mandate insurance coverage for most Americans. In 2014, like you said, it became mandatory to purchase that or obtain insurance. We started with them in September of 2013, getting trained, geared up, ready for open enrollment to begin. In Idaho, they set a lofty goal for us to try and enroll 40,000 Idahoans in the exchange during open enrollment. Idaho reached 76,000, so we exceeded their goal by quite a bit. You talked a little bit about qualifying life events. Those are really anything that makes it so that you're not eligible for the insurance coverage that you already have. And if you chose not to purchase it before, you just didn't know about it, suddenly a light bulb went on and you realized you don't have health insurance and you need it. Some of those events that you talked about, marriage, adoption, having a baby, relocating, moving to another area, a lot of those things will trigger an open enrollment period for you. But it's limited. You can't have moved 6 months ago and then say, oh, I moved, I need insurance. It's like a 30-day window that it opens for you, and you have to contact them. And by purchasing the insurance, you can, when you trigger an open enrollment, then you can go on and purchase insurance and you can avoid the tax penalties. Okay, so for the first year, they're not real stiff. A lot of people look at it and say $95, you know, it's gonna cost me more than that to buy insurance for a year. But as you could see, it quickly escalates the amount that you're gonna have to pay if you're not an insured individual. There's a lot of benefits other than just the fact that you're gonna have a tax penalty if you don't have insurance to purchasing that insurance, okay? Some of the things that it provides are really beneficial to us as a population in the whole. That is preventative care services. That's big in the Affordable Care Act, and the more we can be proactive in our health care versus reactive, the better off we're all gonna be as a nation and as a population. Okay, so the next open enrollment is November 15th through February 15th. Now, a few things that I wanted to just let you know. Somebody asked about the website. It's Your Health Idaho, okay? And that is where the exchange is found. Idaho is a state-run exchange. However, last year for open enrollment, we did partner with the federal exchange because ours was not up and running. That changes this year. It will be up and running for the new open enrollment and going forward. Okay, so Idaho will be a self-run exchange, and it will work really the same. There were several avenues you could use to enroll in insurance. One was to do it yourself. Just go on the computer and go work through it and fill out the application. Just do it yourself, and it wasn't too complicated if you're computer savvy and you know how to do that. But there are people who aren't or don't have access to computers, things like that. And so they provided individuals in many communities that could help with that, and that was in the form of in-person assisters and agents and brokers. So in-person assisters could go in and help you enroll, and then if you had further questions or wanted really a recommendation of a plan, we would send you to an agent or broker who could further help you with that. But a lot of people chose to just enroll with in-person assisters. I think the number they gave us was 26,000 of those 76,000 enrolled directly with in-person assisters, and the rest either did it on their own or through an agent or broker. So it was a really successful program in the state, and was really able to get a lot of individuals who weren't aware of what it was, didn't know what was going on, really could benefit from having health insurance. We were able to really help a lot of people get to that point. Okay. With me tonight is Gary, and he is going to talk to you guys about how the Affordable Care Act affects us as a public health district. Okay, so we're with, like I told you, Eastern Idaho Public Health District. We cover 8 counties, and Idaho Falls is as far south as we go, but we go all the way to Salmon and Chalice and Driggs and St. Anthony and Rexburg and Rigby, Mud Lake, Du Bois. We have offices all over to help provide some of these services that people need and that maybe aren't accessible in other areas for them. Let me really quick let you know, we do have some information up here about the Affordable Care Act. We have pamphlets available for all of you on, so this one is the preventative services that the Affordable Care Act requires to be available on plans. Some general information about the Affordable Care Act, a specific pamphlet for women, so the services that are provided for women specifically under this. And then this one is for seniors, which a couple of us in here qualify.
You looked at me, I saw it.
I said us. And then we have one about public health and the services that we provide. Okay, so these are available for you guys to help yourselves do afterwards. And does anybody have any questions for me about things that they presented in their slideshow or in their PowerPoint?
We both out of the Idaho Falls office, Rexburg office?
We both work out of Idaho Falls.
And there's a Rexburg office?
There's a Rexburg office, yes. And Gary's actually over Family and Community Health Services for all of our district. So, and then I have a billing for all of the district. So, a question over here, yes, I have.
Yeah, I was just wondering if you could kind of clarify in case anyone got confused. It was the sharing subsidies?
Okay, so the subsidies. So anybody who makes 100 to 400% of federal poverty level qualified for some subsidies to help pay for their insurance premiums. So the lower the amount, you know, the closer to 100% you were, the higher the subsidies were that you got. And then the other piece of that was a cap on your out-of-pocket maximum. So the cost sharing portion of it, okay? That's where the cost sharing comes in, is if you purchased so the bronze level plans had, you know, they were a 60-40 plan, and a lot of those, if you went with a bronze plan, your premiums might be paid in full because the amount of your premium credit is based on a silver plan. Okay. So the silver plans is where kind of you get the biggest bang for your buck. You get the subsidies, and your subsidies the same regardless of which plan you pick. You're still going to get the same amount of monthly credit. But a silver plan is going to give you the lowest deductibles and the lowest out-of-pocket. But also, the silver plan is where those cost-sharing subsidies are going to kick in that will help reduce that out-of-pocket maximum. So you might come across a bronze plan and you're going to only pay, you know, $20 a month for it, but it's a 60-40 plan, and your out-of-pocket maximum is going to be $2,500. Where if you get up to a silver plan, it's a 70-30, and you might only pay a few dollars more a month, but you're going to have a $700 out-of-pocket maximum. So quite a bit of difference there. And it really plays into effect in your kind of age group, because you are going to be, you know, having babies, those kinds of things, or very active in skydiving and those kinds of things. So it's very important that when you're looking at healthcare plans that you're not just looking at, this is my monthly premium, but looking at the whole big picture of it. This is my monthly premium, but this is also my out-of-pocket, and this is also the percentage I have to pay after I reach my deductible. Deductibles are a big part of that too. You know, you might have a $200 deductible on a silver plan and a $700 deductible on a bronze plan. Well, that's a big difference when you're talking, you know, your upfront costs. Okay, any other questions? No? Okay, then I'm going to turn the time over to Gary.
Great.
Thanks, Sandy. Thanks for having me, us, and addressing the topic. It's could be one of the most significant public health efforts seen in this country since vaccines or since clean water. But it's, and there's no politics involved with this effort at all. I'm glad we're not, it's not my intention to make it a political thing. I think it's important to discuss the impacts and the facts about it, and leave you to your own political ideas about it. So thanks for the tie comment. Any idea what that's all about? 5 visits to the pediatrician by 5 years old gets your child completely immunized. So, and as I said, immunizations have been a huge public health preventive effort and saved lots of costs and lots of lives. So I've been in public health for 29 years and a registered nurse for 32. And like I said, the Affordable Care Act is a huge effort to try to get the population of the United States insured and to lower health care insurance. I think you guys did a nice job of giving a good round picture of this. And do health insurance costs, is that a factor for anyone? I can tell you as a division director who watches budgets and puts them together, oh boy, at least 2 out of the last 3 or 2 out of the last 4, we've had to cover an additional $1,000 per employee per year cost for health insurance. And if you're HR, you guys know about the cost of health insurance. That's $200,000 for 100 employees. That's a couple $100 grand that no one fully helps me support the offset those costs. The legislature supports us somewhat, counties support us somewhat, fees and contracts support us somewhat. But we have to scramble. And we as a nation can't, we as a department, you as a college can't afford to continue to get those huge increases. So this is one effort, not only to control costs, but to provide health care to Americans. So as a public health official, I'm thrilled with some of the requirements that health insurances must offer to those who are covered. And that's all the preventive stuff that Sandy referenced and are located here. And also were addressed somewhat, but particularly the preventive health insurance. Every plan must have a preventive health insurance component. And all those on the exchange do have that. They're qualified or they wouldn't be up there. Now, for instance, Blue Cross of Idaho, who is our insurer, was grandfathered into the Affordable Care Act. They don't mimic the Affordable Care Act requirements for health insurance plans verbatim, but we're close enough. And maybe, for instance, I'll just reference, maybe you have, Aetna of Idaho, and your plan for the college was close enough to the Affordable Care Act requirements that the government allowed Aetna of Idaho to be grandfathered into the Affordable Care Act requirements. So you'll see folks like me, I may have a little deductible yet or a co-pay for some of my preventive services. Those who insurance plans that are on the exchange require that you have these preventive services with no deductible, no co-pay for the recipient of that plan, which then is going to encourage individuals on these plans to take advantage of the preventive services because it's free and it will promote long-term health. So some of those preventive services for children: autistic screening at 18 and 24 months, congenital hypothyroid screening, developmental screening for under 3-year-olds, all the immunizations for children, vision, hearing screening, hearing screening rather. For women, well women visits, gestational diabetes screening, human papillomavirus testing, which is cervical cancer prevention testing every 3 years, domestic violence screening and counseling and screening for HIV, human immunodeficiency virus, contraceptive methods, breastfeeding support and supplies, mammogram visits every 1 to 2 years. There's others of these for seniors and for all adults and or all children. And it goes without saying, but I'm going to say it because I think we don't hear it enough. You've heard in some of your classes maybe, and I know that, for instance, whether in family planning, $1 spent on preventive services saves you $6 down the road for unplanned children, C-sections where there's no prenatal care, etc. $1 spent on an immunization saves lots of money on diseases that show up if you're not protected. And you know about diseases that show up when you're not protected, or even when you are pertussis. The rates of pertussis in Idaho are exceeding any in the last decade or more, and that's a real concern. So increased prevention results in decreased illness, increased health, should result in decreased insurance costs and decreased premiums because we're not using the system more. Part of the idea of the Affordable Care Act is to change the paradigm in America from a fee-for-service. The Western health model is fee-for-service interventions. We take care of ill people, provide services, interventions, drugs, treatments, and bill for all those services. To shift that paradigm into, let's keep people healthy so that we don't have to do all these interventions, will, in the long term, reduce the number of things we have to do to people because they're staying healthy longer, and then reduce healthcare costs. Will this work? I was telling Sandy, I hope, I may not know, I'm going to live a long time, so maybe I'll know in my lifetime. But this is not an overnight thing. This is going to take quite a while there's still a lot of people who aren't insured, and so we're still going to have numbers of sick individuals. When you're not insured, being in public health for a long time, I've seen lots of uninsured individuals and the struggle and choices they have to make with sick children or being sick themselves. They delay as long as possible until it becomes a crisis or an emergency, and they show up in emergency rooms. And I don't know if anyone's ever been in an emergency room or got a bill from one when you did, but it's not a fun experience. It's huge. It can bankrupt you. Some of the largest cause of bankruptcy in the United States is medical bankruptcies. And so that's not acceptable really from a public health and a humane person perspective, from my perspective. So I think I've talked enough about public health perspective and the preventive health services, that aspect of this Affordable Care Act. You know, there's so much about this act that apparently it's pretty thick. And it talks about how these costs are funneled and all sorts of regulation on insurance industry, that only so much of the premium can go into administrative salaries. 80 to 85% of the premium has to pay for your health care. So if some companies who were throwing rate increases out and they're only spending 70% of those premium dollars on health care, they don't have that premium approved and they're not able to participate in exchanges. Now you and I as private citizens can still choose to buy those plans should we want to, but you're paying much more of your dollars paying for you know, the yacht and the cruising. I think that's enough from my perspective at this point, and you're welcome to ask. I think the request was to save questions until after we're done.
All right, can you pull up the BYU-I homepage for me real quick? Yeah, the Max scared me, so he's a Mac man. So we'll have him pull that up. We're going to give you a perspective, a little bit more of a perspective from an employer and an educational employer. There are some different rules and regulations that apply to educational institutions. And we have been working on this a couple of years.
Extensive efforts.
A couple of years, and there have been a few of us that have been working on this from the university. One of the individuals who spent a lot of time on this is in Salt Lake today, so wasn't able to be with us, but he's helped us. Myself, TJ, our director, we've met. We met for a number, probably a year. We would go down, for some time we were going down every 2 weeks down to Salt Lake, meeting with our insurance company, who is the insurance provider for BYU Idaho, as well as for church employment. So we're talking about church office building, BYU, the church farms, you know, all those kinds of things. Some of you probably heard Deseret Mutual or DMBA. That's the insurance provider, and it's I think it's fair to say I don't know if it's a nonprofit. It's the board of directors who oversees it is the church. But it's a fully operating insurance company and financial planning and retirement company and all that kind of thing. So we met with them a number of times. One of the interesting things that we had to do was to figure out not only for our institution, for BYU Idaho, but for all of the other institutions, how this was going to play out. Because as part of the rules of ACA, there were some regulations that applied to all of the church, all of the church employees under the church umbrella. And so we had to do a lot of coordinating. So it was fairly complicated getting all of our different systems at every different employer. Because we also have not only educational institutions, we've got Deseret Book and I don't know, some of the
church funds.
Yeah, lots of different. So we've got educational institutions. We've got lots of other kinds of institutions out there. So all of these had to then communicate with their computer systems, and we had to have a way to track, because there are certain regulations in Obamacare that we have to We have to have a certain amount of people covered. We have to offer a certain amount of coverage. You know, we have to report all of those numbers, and so gathering them was a huge chore. I probably should mention that we had one of our programmers here who spent a significant amount of time writing a program that would allow us within our own systems at the university, because every institution, well, particularly the larger institutions, will have a number of different computer platforms and computer programs that have to communicate. So we had to do that, as well as connect with DNBA's computer system, which was gleaning information from all of the other institutions within church employment. So we spent a lot of time driving back and forth to Salt Lake City.
Good conversation.
Yeah, it was great. And it's there are lots of regulations that employers need to understand. Some employers who offered insurance, you know, for full-time employees, would not see a whole lot of change as long as it was well defined within their organization, who was full-time and benefited, who was part-time. If you had employees who were kind of riding the line between full and part-time employment, say working 30 hours a week, some institutions, like our institution within the church system, our institution at 30 hours would give people full benefits. There are other institutions within the church entity that didn't at 30 hours. They would wait until they were 40 hours before they were considered fully benefited. But the law requires that once you hit 30 hours, if you average 30 hours over a measurement period, then the employer is required to offer you health insurance. So for a lot of institutions, especially educational institutions, where a lot of adjunct faculty members and others were working about 30 hours, they were going to see a difference in hundreds and hundreds of thousands of dollars on their what they were going to be paying as an institution for health insurance. So there became a very quick scramble as to how to define a full-time employee, benefited employee, and a part-time, and putting things in place that would minimize the impact that it had on institutions, just for the institution's survival. Anyway, that's been an interesting challenge. But you have a question?
I wanted to know the penalty.
Yeah.
So, say after this amount of time, I know it's different. You can kind of choose what your time is, but after that period of time, when you've got an employee who's averaged 30 or more, and you've got a report or you're audited or whatever,
Right.
what's the kind of penalty for just one employee?
So you're talking the measurement periods.
Yeah, I just want to know if you do break the rule,
Right. What's the penalty?
Yeah.
Big stick.
Yeah. No, it's pretty large.
I was thinking once we were done with this, I'd pull it up and kind of
That's
draw
fine.
and talk about
Okay.
some of that, because it's a
It's that,
complicated subject.
yeah, it's complicated, but it's thousands of dollars per employee. And there can be a very large penalty given to your institution if you're not within compliance of a certain percentage. And so we had to have that apply to the entire umbrella of the church system, not just our institution. So we have to know who's getting covered at BYU and what their percentage is. So all this has to be communicated in a computer system so that we don't get fined thousands and thousands of dollars. So,
And we also have that responsibility to care for the other employers too, right? So we've got to make sure we're not messing up on our end, or it's going to impact all these other desert industries, the church
Oh, right.
farms,
yeah, exactly. So if we're not covered, if we're doing something wrong here, then if it puts everybody under the umbrella out of compliance, then guess who's mad at us? It's not a pretty picture. One of the other, let's see here, I was thinking, should we go through, let's go through, this is, just go into the,
you want to see the policy.
yeah, let's go into the policy page. So we've got some references. Your presentation was fantastic.
Yeah. So I was thinking, we're done, the experts already spoke.
Yeah, you said, I'm not an expert or anything. I'm like, well, that's dang good. So, I mean, you covered it very well. And you've got to understand that we're talking about tens of thousands of pages of legislation. So this is a very complicated and very heated type of thing. So we talk about the political implications and you know, the people weighing in on social kinds of justice, all those kinds of things. It's very heated. And so I thought your presentation was fantastic. We haven't done a ton of research into the side like these folks have done with the public health, actually from the user's end, you know, from somebody going out to sign up through the exchange or through the marketplace is another name for it. So fantastic resources right here. But we've spent a lot of our time trying to get the university ready to implement this, have our systems in place so that we could give the necessary information to the government that they needed to know so they could assess who was insured and who wasn't, and who actually to give the penalty to, okay? Because like for me, as a father, if I have children who are under 26 and I don't cover them, somebody's going to get a bill, and it's not going to be my kids, okay? So we're having to gather information on our employees, who their children are, their social security, those types of things, so that we can track who's covered and who's not.
Just to clarify,
Yeah.
your children that are over 18 are still responsible for themselves.
Okay.
So you can carry them on your insurance.
We can up till 26.
You can until 26.
Right.
You're not required to.
Right. And if I'm not
If you're
required
not
to,
required
and
to-
they're younger than 18. If they're
younger
younger,
than
I still get a
18, you're
bill.
responsible for.
Right.
Over
18 is
18,
the- okay.
they're responsible.
Okay, so if I've got a child that, you know, is 14 or 15 or 10 or whatever, I'm responsible for providing their insurance for them. They can stay on my insurance if I allow them to. They can stay on up until 26, which is a helpful thing.
Well, there's
So-
a bigger impact to that, I think, comes to you folks, as you get married and have younger kids and maybe not a full-time job where you have insurance. These are some serious concerns for you guys. You need to be prepared. It sounds like we've had some experiences where we've looked at and met those.
Because they're gonna get hit with both. They're gonna get 26 with fall off their parents' insurance,
Yeah.
but they're also gonna have small children.
Right. And of course, it's very beneficial, very inexpensive if you don't have any money. So the system is weighted, you know, I'm sure you've heard this if you watch the news at all, and it was on every channel for a number of months. It's not so much now, but you know, the more you make, the more premium you're going to pay, the more it's going to cost you. So that it all depends on your station. Go out through the marketplace, go out through the exchange. They'll help you figure out what your premiums are. Unless your company offers you insurance, which you have the option, obviously, of taking that insurance. So, do you want to run through?
Yeah,
You
I was
want
just
to?
gonna say, how much
Okay.
time do you want us to?
Sorry, we're combining.
Because
our
honestly, we
minutes.
could take 45 minutes if you want us to. Let's take it on. So it really, a huge portion of this goes credit to Pat and Jeremiah. They did a lion's share of this work, and I've been fortunate to come in behind them, and it's already prepared for me. So it's been a good experience for me to learn from them. And just as you think about it, so the Affordable Care Act, and it's funny because we call it ACA in our business circle. And I saw you guys have the patient protection.
Yeah, we call it PPACA.
Yeah, and so if you hear anybody going across campus, that's probably the bus talking about. And so there's these few key provisions, really, I don't know that we need to reiterate. I think you guys hit, for the most part, most of that.
Yeah, beautiful.
There's a few portions in there that pertains particularly to our employees. Like there's flexible spending accounts. You guys are familiar with that from your insurance class. Sounds like some of you have taken that. So those things have adjusted a little bit. Our particular guidelines hit here with BYU Idaho, and the one that I thought you guys would have the most interest in is this student employment portion. Is there anybody here who's employed as a BYU Idaho student? Pretty good portion of it. So we have some pretty strict guidelines that I'm assuming most of you are probably aware of, and hopefully your supervisors for sure are aware of.
And again, the reason behind this is once you tip the scale in a measurement period, once you tip the scale to averaging 30 hours, and we're required to offer you insurance, that costs us a lot of money. So we're not talking about just a few $100s. The plan that the university offers right now, I think I'm okay to say this, we pay approximately $1,700. So that's the employer's portion, $1,700 per month. Per family.
I'm gonna have to report you for telling me.
So if we have just one person who qualifies, okay, so we've got our institutional budget. We have one more person that qualifies. You take 1,700 times 12, and that's what you add to our budget. So if we're careless about this, I mean, it can cost us hundreds of thousands of dollars, and then obviously, if we're not in compliance, it can cost us hundreds of thousands of dollars. So, as a way to manage the budget, we've had to put some pretty strict guidelines in as to how long people can work.
And to go off of that, I think when you work with your employer, I don't know of too many Americans that think, oh, you don't deserve health care, I hate you, die, you know. I don't think an employer looks at it that way. I know we don't. If we had the budget, oh, it'd be great to insure everybody and just take care of you. And so really the employers are restricted by that budget. That's where the hardship comes in. So we have to make these strict rules, and then people think, oh, my employer hates me. No, we love you. That's why we want to maintain our budget and keep our business viable so we don't fall apart and then you don't even have any income.
Okay, so you guys said 30 hours. So do they put a 20-hour limit on it just to have 10 hours of leeway just to make sure no one goes over?
And so here's where we come into the complication, where we're a little different than a normal business, right? We have students that work for us. You guys have internships. And so we've got different things we need to plan for and try to do this blanket protection. And it's complicated. It's really what it comes down to. So we have this first portion here that you guys are, most of you who are employed are probably doing that. You're working the 20 hours a week, and that's your limit.
And there are also tax implications as well. Once you're not operating essentially as a full-time student, and it looks like, hey, you're a full-time employee, then you and the institution are going to have to pay FICA taxes. So that also affects the institution. So there are a lot of behind-the-scenes things that help get us to this 20-hour thing that we use for students.
And so that's the primary protection to that expense there. There's this, we do allow students 1 40-hour per week semester per year. If you do a paid internship with one of the departments on campus, that'll hit it. If you do something with one of the farms, if we let you work 28 hours a week, you wouldn't have that as an option. You wouldn't be able to do your paid internship at the farms or at the university. And so that's one other protection on it. The 7-week break, just so you're aware, counts as one of those semesters. So we're really broken up into 4 quarters in a year at BYU Idaho for our students. The 7-week break may not be a full-size quarter. The other may be a little bigger, but the math works to where you can have one of those as an option. And if you have questions as I go along, feel free to jump in there. You're definitely not allowed to work more than 1,500 hours in a given measurement period, and we'll talk about those measurement periods. But out of curiosity, are you guys, who's all familiar? Are you familiar with measurement periods? Okay.
And it correlates pretty well with open enrollment, and there are certain times that you sign up, there are certain periods that we measure to see if you've met the 30-hour average. There are certain periods where we have to offer you insurance. So if you meet the 30-hour average, then that next year, for a full year, we're required to offer you coverage. Okay, even if you only work 1 hour per week, we're required to offer you coverage. So So they kind of correspond with the enrollment periods.
Is the fiscal year for BYU Idaho in October?
Actually, the fiscal year is January to December, but this has to mesh with all of the other institutions that we have, as well as some of the legal requirements. So, but we changed it about maybe 10 years ago, going from our fiscal year being August to August. Now we do January to January essentially.
So the measurement periods kind of line up with the academic year too, which is somewhat
So with that, if you average 30 years, then you have to offer insurance to that person. What if it's like their senior year and they just do like their last semester, they put in, go above that and go 30?
Right.
What happens? Because you're not going to offer, they're not an employee anymore.
Right. If they're not an employee, then you're not having to offer them insurance. But if they're employed any amount of time at all, you're offering them insurance while they're employed. Yeah.
So this 30-hour range, does that depend on the state or is that national?
No, that's I think that's the federal law, national average.
Yeah.
Yeah.
Okay.
Yep.
So is it okay, because I'm thinking of like families that have, two, both the husband and wife work, let's say the wife is a teacher and she doesn't get insurance through her school, like she opts out of it because she goes with her husband. Would the school be in trouble because they're not giving her insurance, or is it's okay?
No, it's for the employee.
Okay.
Some organizations are going to offer it for the whole family, but the requirement is they offer it to the employee.
That's a good question. Any others?
So with the student employment thing, is it completely voided for international students, or do you have to follow the same regulations?
International students are a different flavor for sure.
Okay, alright.
There's other regulations around them.
Just
yeah.
But if they're, from what I understand, some of the latest stuff that I read is maybe you can help me too if you know this. But with international students, if they're employed in a business that operates within the United States, they're working within the United States, then they should be covered as well. So I don't know if clarification or anything on that. That's the latest that I've heard is as long as they're operating, the business is within the United States, then you have to offer them insurance as well.
To get back to your point real quick about that clarification, as long as the employer offers, then they're okay. The employee can change their mind and go a different route if they wanted to.
A lot of it has to do with filing status.
Mm-hmm.
So, as far as the
Yeah.
requirements. So if it's somebody who is not required to file a tax return, then the employer may still have a penalty if they're not offering it to them.
Right.
But the employee would not necessarily have a penalty because they're not required to file a tax return.
Right. Yep. So are they a U.S. citizen? Are they here? What was you had it up on your slide, a U.S. citizen or a legal residence or something? So it depends a little bit on what you're reporting, what your relationship is to the United States government. So that's a great clarification.
Any other questions on student employment at all? That's kind of it. Go ahead.
Mine's more general. So I do want to know about what the penalties are still for someone. Say, for instance, I'm interning right now, and there's a position that they can't maintain. They keep losing people, and so they constantly have employees that are working too long, and they're not receiving those benefits. What if
So you're curious about the penalty for the employer?
For the employer, yeah, because a lot of us are healthcare administration majors, and we're going to be running hospitals or long-term care facilities and medical practices, stuff like that. Say we broke a rule, I would like to know the penalty.
Yeah, it's significant. So it's $2,000 per person right now, per employee, for each employee. So if one of them, how many people fall out? Is it just one? Or is it a percentage?
Right now,
I think there's a percentage.
Yeah, right now I think it's 30%, but in 2015, so they gave a little wiggle room this year, and then next year it's going to be 95. I think originally it was written to be 95 or 90, so high 90s.
So they're going to allow us to morph into it to make sure we get our stuff in order. So early on right now, we can have 30% of our employees fall out of compliance and they're still not getting penalized. But the idea is it'll get up to that tight threshold where some fall out. It wouldn't just be, okay, say Pat and I, we go and we get healthcare through the healthcare exchange, even though our employer should be offering it by law, we somehow get through that and 31% of us do it. Then our employer has to pay $2,000 per person per employee.
That's it though?
That's it for now, whether it adjusts or not.
But if you're out of, there's a per person who's not, so there's a penalty for that, but also there's a penalty if you in general fall out of compliance, then it's I think it's $2,000 or $3,000 per employee, period. So if you have 1,000 employees, what are we talking? $2 million.
That's what I mean. It's per each employee.
$2 million. So there's an individual kind of an individual penalty, but there's also a penalty that if you're out of compliance in general with their 70% or 95% or whatever that thing is. So if I don't offer, so if there's one person I don't offer, say Mason, I don't offer Mason insurance, I'm paying $2,000 penalty.
That makes sense.
Okay,
So
if I'm out of compliance as an institution, then it's it's huge. It's per employee. So I look at the number of employees I have and I take it times 2,000 or 3,000, I can't remember the number, but I take it times that amount and that's what the penalty is that I pay. So it's like a million.
And I believe that's full-time equivalent employees.
Full-time FTE, full-time equivalent employees, that's right.
So it's not just, I mean, they count each half-time employee, 2 of those counts for 1 full-time employee, as far as assessing the penalty.
In the bigger picture too, though, there's an argument saying if you take on the penalties, it'll save that business potentially some money. It just depends on the size of the business.
If you're, the deal is though, if it's just, as long as, the key is, if I say, I'm not going to give it to 5 people, but I'm still in compliance with their 70 now, 90 or 95 next year, it is, if I say, okay, I'm not gonna give it to these people and I'm just gonna pay $2,000, I'm just gonna pay the penalty for them, that's all I have to pay, okay, is $2,000, $4,000, $6,000, $8,000. But if I'm not in compliance with their standard of 70, 90, 95, then I'm paying a huge amount.
On top of it? Oh, okay, wow.
So I could let a few go. I could say, you know, this would be discriminatory, but I'd say, I don't like Mason, you know, and whatever. And I'd say, I'm not gonna offer it to him.
It's because of all those mason jars that you might have had as a kid.
Yeah. So I could say, I'm not giving it to Mason, or I'm gonna calculate it out just so narrowly, so I can save myself money, so I don't have to pay $17,000 or $20,000, whatever it is, in benefits. I'm just gonna pay $2,000. So I'm just gonna do that, okay? But if I'm out of compliance generally as an organization, and I'm not covering a certain percentage of my employees, then I'm gonna be fined a huge amount of money.
Okay. And that wouldn't be worth it, obviously.
That would be very expensive.
Good.
Yeah. Why do you
make this law?
Unless you said, right, unless you said, we're not offering insurance anymore. Okay, so there's not even an option for Mason to come to me and say, hey, you know, I'm a full-time employee, I'm here for my insurance, and I say, we don't offer any. Okay, then I'm not gonna be penalized, I don't even offer a program. Okay, so then I just pay the $2,000 per kid, you know, I'm thinking my kids, per employee, and I just say, I just pay, okay, that's just what I pay. But if I offer insurance and I don't cover people, then I can get in trouble. So, hopefully that clears it up. Is there any clarification, questions?
When you're talking about a complicated law, it's hard to.
And some of it's still being battled out because some of this has been pushed back, some of it's being debated right now, but at this point in time, that's the way we understand it.
So your main goal, right? Everybody in here wants to run a healthcare organization. Is that kind of the idea mostly? Okay. So maybe it would be valuable to hit on each of these. I was going to cruise past most of this, but Just to
I'm
give you
gonna,
some
I'm gonna
perspective.
have a chair. You wanna finish up, and then, sorry, we don't wanna go too wild here, but,
I think you need to stay in the sheet, but you can sit down now.
okay.
So if you have a question, that's bad. If I misrepresent correctly. So you come into complications because when you look at an employer, you think, oh, they're just employees. No, there's different flavors of types of employees, right? So we've got part-time exempt or contracted employees. We've got one-year faculty here at BYU Idaho. We have adjunct faculty here at BYU Idaho. We have online faculty. You know, we've got student employees. All these have different ways that they impact our business, and different ways we have to count hours.
And we have employees, and because of the online, we have employees in a number of different states.
Multiple states.
So we have to figure out what the laws in that state are and comply with those laws.
Right. And so when you go forward, you think about this and running an organization, you're gonna have to be aware of how each employee's hours are managed. So the part-time, you know, obviously half-time or less is how we do. Actually, it's 29.9 hours in this, right? That's how we do. Then there's part-time exempt. And so we built into our guidelines some different regulations around each one. And the whole point of building this in goes into that conversation of measurement period, how that fits in the picture. I just hate for you guys later on Wednesday.
There's
As
another,
exciting as this all is.
there's another a category up here, which is, and because there are a gazillion ways to employ somebody. So you've got seasonal employees. So employers are like, well, how do seasonal employees fit into this? I just want to hire them for 60 hours a week over Thanksgiving, Christmas, you know, over the holidays. Well, what if they qualify? What if they meet the 30-hour average? Then what do we do? So there's a debate out there whether or not you can count seasonal employees as regular employees. And so there's special rules and regulations for that. Special rules and regulations for adjunct, because an adjunct professor will teach for a certain amount of time. What if they're off for the summer and then they teach again in the fall? Do I have to offer them insurance in between? So there are regulations for break periods, how long the break periods are. We have to give them, this is making it way more complicated than you probably ever wanted to know. But 501 hours, so we give them a certain amount of hours under certain conditions, and that's required by the law.
I think it's good though, it's
So-
testing the waters. You guys wanna not monitor this stuff? And so out of curiosity, adjunct, you guys know what an adjunct is? Basically a part-time professor. I just learned that a few years back. A little slow, I guess. And so when you're looking at all these, there's another layer of complication, because you're gonna have a part-time employee go to a full-time employee. You're gonna have a full-time employee go to part-time, and so you've gotta monitor all that stuff. Again, the measurement period comes into that transition from full-time to part-time, because there's the first measurement period, stability period, which comes after. So we'll talk a little bit about that. Cruise down here. So we address that here, our transitions from full-time to part-time. Then we also have the complication of a retiring employee. There's concerns there of making sure things are appropriately addressed according to the law.
A good point here. A lot of companies, once an employee retires, they don't offer any more insurance. Some employers do. The church happens to offer insurance for retirees. Okay, but how does that qualify? Do our retirement programs qualify as legitimate under the ACA? And once you're no longer a full-time employee, what are the rules and regulations for that? So we monitor, have to monitor that as well.
So I'm gonna do my best on this measurement period stuff. And if you guys are bored, say quit and stop. So we've got January to December. I probably should have drawn that smaller, right, because they overlap. Anyway, so there's an initial measurement period. Let's say, in fact, I'm going to change this already. I should have brought that PowerPoint slide that was prepared by DMBA. It was a beautiful representation of it. I'm going to change that. So there's a year. Each one of those represents a year. And let's say this is for, I'm just going to use BYU Idaho's perspective because it's more simple for my brain to handle. So we've got, it's October, I almost said August. October to October is our measurement period. This top one I'm going to call a standard measurement period. When an employee is full-time like Pat and I, we're measured to see if we reach over 30 hours. Obviously, we're full-time, so yes, we would. But for Mason, who works in our office, or Danny, who works in our office, we're going to measure them through that whole period there. And if they go over the 30 hours, they become eligible, and we have to offer insurance to them and all that. So we went over the rules to monitor that. Because what's going to happen is not everybody's hired in October, right? So sometimes people are hired in, let's just say August. So they're going to have what we call an initial measurement period that comes into effect. It's going to catch this first year of employment. And if an employee reaches over 30 hours within that first year, then they become eligible. And then next year is called a stability period. And let's say I did this. I went full-time for this first year. I obviously had insurance as part of my package. That second year, I dropped to part-time. I'm still eligible for this stability period, even though my normal job as a part-time person doesn't qualify me. So say I'm only working 20 hours a week here, but they still have to cover me for a stability period. So it's a weird way to make sure that we get everybody covered appropriately. It's mind-boggling to try.
So, and they're both going on at the same time, so this is what we had to build into our computer system, is 2 different measurement periods. So we're tracking people's hours all the time. So from the time they start, we're tracking, and we're also doing another tracking that's October 15th to October 15th.
And so you'll get double measured right there. And so at the end of this period, if you haven't reached 1,000 hours, or 1,000 hours, sorry, I also do financial benefits, and that's the 1,000 hours. If you haven't reached 30 hours average here, you might still need it in this next standard period, which overlaps your initial measurement. And so I think for the most part, that's what I want to show you guys, is there's just kind of a complication. And then when you take in our perspective of multiple employers, multiple levels of employees, it gets quite complicated for an employer. Administratively expensive. The amount of hours that have gone in to understand this, to make it work, the software that goes into this, the programmers that have had to help us develop things to measure and monitor this, it's expensive. It's a complication. But hopefully in the end, and I appreciated so much your comments, that it becomes the best thing for this country. Hopefully more people are covered and taken care of. And I think that's everybody's hope. Politically in favor of it or not, that's where we're at. Any questions on the measurement period stuff? Did we answer some of your stuff? Okay. There's more we can talk about. But anyway, that's it for the most part.
Thank you. We're now going to open up to just general questions. So if you thought of a question that you didn't get asked, now's the time. You guys can stand.
Do you want us to stand up here?
There are chairs if you'd like to sit. Does anyone have any questions?
Well, I got a couple questions, but first to start off, which demographic is affected most by this? Is it the lower class, middle class, or upper class? Which, I guess.
Depends how you define affected. Everybody's affected.
Right. I mean, I was previously working, my dad was unemployed, and I was previously working for DirecTV. And I know our insurance costs when they presented the new plan was close to $200 more expensive. So just looking at private insurance, it was almost impossible to afford. So I know like a lot of those people that are in that kind of demographic are, really affected. I just didn't know. Overall, was this everyone?
That's part of the heated debate is who's paying what and how much and all of that type of thing.
It's employer things too. You know, we as a health district and statewide employers cover a good portion of the premium of health insurance versus some school districts or some other employers, and that's just variable based on their policy. And at one point, as I was saying, with those $1,000 per employee per month increases, you can only go so long before you have to say, well, I guess we have to close the Rexburg office or have all of our employees pay $50 more per month.
Gotcha.
And yeah, at one point, we don't want to increase the cost per employee, because at one point we become less desirable employer. And it's a fine line.
Yeah, that's a good point, because an institution is going to have a certain amount of costs that are incurred with healthcare, and they're trying to figure out how much to charge to meet their bottom line. But then when you go out to the marketplace, out to the exchange, there's money that has to make that work as well, which ties into state money and federal money, and so it's going to depend a little bit on your situation. But I know that there are some that have had a great deal. A lot of people are covered that have never been covered before, and some people on the other end that are having to pay more. So it's a bit complicated.
The whole idea is the 47 million people who are uninsured, this plan, and I don't know, resulted in a portion of the population being uninsured, and I don't know who that is, but the idea is if 40 million of those 47 million are now paying on one level or another fully or subsidized by taxes or insurance and pharmaceutical company pitches in, the overall payers result in less premium cost, logically. And again, when will we see that? We're gonna clap loudly when we do. I don't know when it will be.
We did see in Idaho, though, of the people who were enrolled, we just saw these numbers yesterday, actually, 18 to 34-year-olds were the highest population that enrolled in the health insurance exchange. And then the next highest population was 55 to 64-year-olds. So that was kind of it was, I think, 27 and 24%, was that right?
Something like that, yeah.
Of the people who enrolled on the exchange. So it's really that population that is realizing that this is something that's going to be really beneficial to them. Of the people who enrolled in the exchange, better than 90% of them were able to get subsidies for their insurance through the exchange, and primarily they picked silver plans, just for that, throw that information out there. But it was interesting numbers that came back, and we had to wait a little while to get those because we had to get them from the federal exchange because we went through them. But that was for the statewide.
You saw on the slide all the numbers of folks who were uninsured, the 47 million, and some are choosing not to, and some are healthy young kids. And so it's the healthy population that the ACA really wants to get into this because it won't cost us, but there's a portion of payments that go into the system to help those who are sick to cover those costs. So if the healthy population doesn't get in as payors, we haven't gained anything.
And that was the greatest fear, was that the only people who would sign up for the health insurance exchange are the people who couldn't get insurance before because they were too sick to get it.
Pre-existing conditions.
Right, pre-existing conditions, those kinds of things, but that was not what transpired at all. So, I mean, they signed up too, but they anticipate there won't be a big increase in the rates that are offered next year because of the fact that this large population of people who fall into that, healthy range, 18 to 34-year-olds, signed up.
And just an anecdotal comment. So, I would like to retire before Medicare age, and this allows me to. Whereas, and you have employees who are 61, 2, 3, 4, who maybe should retire. But my goodness, you see what health insurance costs. If you guys offer some health insurance apparently to retirees. My employee does not. My employer does not. So if I retire at 60, I'm on my own until 65. And so you'll have those folks hanging around an employer just because of no health insurance. And that's not healthy. That's not healthy. It's not healthy for the individual because you're not engaged, you're not happy, and it's not healthy for the employer because you tend to be not contributing as much. So I went on and put my numbers in with one of the in-person assisters and said, let's say I'm retiring tomorrow. Let's say my income is 50 grand. Let's pick a plan for me and how much is it going to cost me. And I got a silver plan with decent deductibles, decent out-of-pockets for $500 a month. And I compared that with Medicare. Part B is gonna be $200-300 more a month. Medicare Part A is free. That's hospital, major medical. And then Part B is the additional stuff, a couple $300 a month. Then Part D is the prescription co-pays, which is another $100 to $200. So I'm in the ballpark. It may be a little more expensive now, you know, at the $465, but I'm in the ballpark to, I already better be budgeting for that Medicare, those Medicare costs in my retirement plan. If I can cover those costs now, I'm ready to go ski in foreign countries.
If I could jump on here real quick with this, I work with our upcoming retirees and retirees on campus. If I could press one thing on your mind today, it's plan for retirement. As soon as you can, start saving money. Things are changing. The better you are prepared, the more enjoyable your retirement will be. The health of your
You know, kind of another question. I saw all the states that were expanding Medicaid. You know, and I'm kind of looking at things from a different perspective too, because I want to become a doctor, specifically an oncologist. And I know right now Medicaid reimburses close to 67% on the dollar, and for specialists even less. So saying that they're going to expand Medicaid, or saying that Obamacare is going to come in, are they going to have the same kind of reimbursement or same kind of structural reimbursement that they already have for a government plan?
You know, and I can't give you real clean info on whether expanded Medicaid expands coverage, but I believe it does some, because Medicaid reimbursement now is terrible.
Yeah.
You know, for dentists and for the medical profession, and even for us, we don't get paid for some of the services we do on Medicaid like we do with other private insurances. But I'm not sure where I was going with that. But so they have to expand some of the coverage somewhat, or all like the question was asked earlier, where's Idaho in Medicaid expansion? They turned it down, and this year it didn't even come up. Last year there was a bill proposing it. It was not let out of committee. This year it didn't come up. And they certainly don't want to call it in Idaho Medicaid expansion. They're thinking of calling it Medicaid redesign, and having some private sector models about that to get our Medicaid eligible men and women with health care coverage. So, you know, that's real important, again, if you're going to maintain health and change the paradigm of letting people just get sick and then do all these interventions and then charge them.
And I love the aspect that it has the preventative care and things like that.
Oh yeah, that's
kind of hopefully stop it before it has to get to a hospital visit.
Exactly.
But granted, along those same lines, I guess I don't quite understand the whole. I don't know. I guess it's really unclear when it comes to the Affordable Care Act in general. Right now, it's required that they accept you regardless of your pre-existing condition. But does that require that a doctor accept you as well as a patient? Like.
No, you're given a plan. You're given a plan. Medicaid is a little different. A lot of times they'll have a medical home where you're assigned to a medical home, and that's you could choose one or another. And those physicians do say, yeah, I'll sign up for that, and I'll accept 1,000 patients. So then that's that arrangement. But no, you know, physicians can choose to limit their practice to. You'll see that as you call. We're not accepting new patients.
Yeah.
That's
or we don't take your insurance. You know, we're not contracted with Blue Cross.
We're not a participating provider, so no, we don't want to take their level of reimbursement.
I assume if you're signed up for medical insurance, they'll tell you your network. You'll have access to where you're
right.
You can go to these 10 physicians participate in this network.
The fact that they did not expand Medicaid was one of the most frustrating things we saw as in-person assisters. Because we had a lot of people that came in that were very interested in having health insurance. They would fall underneath the 100% of federal poverty level, and then they could purchase insurance, but this person who doesn't even make federal poverty level is paying $700, $800, $900 a month for insurance, versus the person that makes 100% of poverty level, so a little bit more than them, is paying $5, $10 a month for insurance. So it was very frustrating, and there was no other option for these people. I mean, there's no Medicaid available for them. There's no health insurance available for them because they certainly couldn't afford those, you know. $700-800 a month premiums. They aren't gonna be penalized. You know, that's the only good news we could tell them, was you're not gonna be penalized on your taxes. But we can't help you in the fact that we still don't have an option for covering you.
Another obvious question that I bring up and is asked me is, so is this going to result in a lot of the federal programs to go away? Like we receive, or the indigent funds. That's how many of the uninsured in Idaho and many states get covered. An uninsured individual ends up in the ER, has no way to pay for that. They don't qualify for Medicaid. Then they go to the county indigent fund, and that's a state and county shared way to cover these hospital and medical expenses. Those are definitely needed to stay intact in Idaho as we sit here. And some of the federal programs like Women's Health Check program. We administer a Women's Health Check program which offers free breast and cervical cancer screening for women, particularly 50 to 64, who are uninsured and are eligible for financially eligible. No, those funds are still going to come down from the federal because so many of those women, 50 to 64, still don't have health insurance. And other programs like that, they're debating it on the federal level. So when do we need to reduce the funding for these because of the Affordable Care Act, yet or not? And thank goodness they've taken a patient approach to wait and see. Let's just wait and see how this all rolls out and what states expand Medicaid and how many people we get covered before we suddenly stop the flow of funds that help preventive services. Like Women's Health Check is a wonderful program. If we can detect early 20 cancers in my district by free breast and cervical cancer screening, what a huge savings on healthcare costs and or contributions to society from early deaths.
I had a question with, and I don't know if you know, but the reason that I've had to, that I couldn't stay on the plan through Cover California is because it was only offered in California. It doesn't cover multi-state. But so I went through Blue Cross there. If I had done a normal Blue Cross plan, not through the exchange, it would have been multi-state. Is that only because I'm going? My husband and I go back and forth to the state, and so I'd like to just be covered the whole entire time, rather than go back and forth from state to state and change exchanges. And so what I'm wondering is does maybe like the federal health exchange, their default programs, is that how do they have any multi-state plans, or is there a way, or is it just kind of?
No, the federal defaults back to state plans.
Okay.
So, other than having a plan, like you say, through regular Blue Cross that you go out and purchase, on your own, not through an exchange, that will allow you to have out-of-state benefits available. But you could look further and see. What did you look and see? Is it really like none of the plans had
the ones that I looked at, no.
Available benefits other places? Because I know most plans, we run into that a little bit with out-of-network areas because we have offices in some rural areas. Chalice and Salmon, they don't have a lot of providers out there. And so we run into that in those areas where they're having to travel, hundreds of miles out of Falls to get services, and they don't have a large list of providers in their area. And so we do see them being able to access services in like neighboring states because that's closer, up in the Panhandle, there's plans that are available that cross the line, into Washington and Idaho. And I know over in Boise they were talking about that, how they had some plans that were Oregon and Idaho based.
And it's how if the plan wants to market itself like in Coeur d'Alene and wants to include, because of the closeness to Spokane and or Montana, wants to include then providers into that plan, then they would for greater marketability.
Question over here.
Yeah. So I'm wondering how the Affordable Care Act affects those who are already on Medicaid. Besides like the state expansion, like are people on Medicaid, can they sign up on the exchange? Or like, are they
If you're eligible for Medicaid, That's your option,
Okay.
basically. If you qualify for Medicaid, they're gonna automatically send that application through to the Medicaid system and qualify you through there. So you can, I guess to answer your question, you can purchase a plan on the exchange, but if you're eligible for Medicaid, you are not eligible for any of the subsidies or any of the financial, I guess, perks of purchasing through the exchange.
So you're encouraged to be on Medicaid.
You are encouraged. Well, they're kind of trying to get away from calling it Medicaid for that
Right.
purpose, because
Yeah.
I kind of see the cringe out there.
I know.
And so we're really trying to get away from calling it that, just because of the negative connotation that for a lot of years has been associated with that. But yeah, you kind of are. And, you know, even split family situations, we saw a lot where the kids actually qualified for Medicaid, even though the parents didn't. And parents would say, well, I don't want my kid on Medicaid. And it's like, oh, okay, well, their insurance is gonna be, you know, very expensive for you to purchase insurance for your kids. You and your wife, cheap insurance. Your kids, not so much. Because that really is, if you qualify for Medicaid, that's really the route.
Good question.
Makes it hard being the law of the land, because if you have preferences against it, you still need to
I know.
get that covered.
And I try to, I have this conversation, just what you're talking about, and I try to view it as, this is America's attempt, first attempt probably, to try to cover our population with health insurance. And this is the way we've chosen to do it. It's not perfect, it may work, it may not, but if indeed this is how we hope to cover our population in yearn for a healthy population in the future, then it's just a tiered approach. It's those who are wealthy can buy their own and do, or own the company and insure everybody, and they do. Those who can't and don't, do they still deserve health insurance? My philosophy is everyone deserves health insurance. Everyone deserves to be able to go to a doctor and bring your child to a doctor when they have an ear infection. And so I just say it's a tiered, cost-shared America's law of the land healthcare plan. And if we can get that philosophy out there, but I know folks who say, oh, I got referred to the Medicaid section and I don't believe, or I don't want to have that around my neck. That's unfortunate, I understand it. But, and that's us changing that paradigm.
All right, are there any last questions?
I think all they're thinking is cookies.
All right,
I'm
thank
just
you.
kidding. I admire you guys for all your work you're doing, so keep it up.
Yeah, absolutely.
The future of healthcare.
And to Gary and Sandy, awesome. You know,
Thank you.
You've had that.
Yeah.
It's our home. You guys, so